Thank you, BK. So we're going to do what we're doing at the end of each of these sessions in this room, just do a couple cases, and if you have questions, certainly you can come to the front or use the app. So you've heard a little bit about the Caseppt classification. C1, telangiectasias, you got to know this. If you're going to be treating venous disease, you got to know this cold. C2, varicose veins. There's a new one that we needed, C2R, which is recurrent varicose veins. C3 is edema. C4A, pigmentation. C4B, full, lacrimatosclerosis of the skin. C4C is a corona that Ed mentioned. Healed ulcer and open ulcer. You had a question, Lowell, real quick, or? Okay. So here's a case. 60-year-old man came in with this. He had great saphenous vein reflux, a little bit of opening down here. And I did a routine RF ablation phlebectomy and probably dropped a little foam down here. And 1 week later, he comes in complaining of pain. So this doesn't project well, but in duration, right along the course of the saphenous on the medial thigh, and erythema at the access site. So, Ed, what are you thinking here? What would you do?
Well, would definitely scan it to make sure there's no DVT or anything else. That looks like a kind of a thrombophlebitis of the vein, just inflammation. I would probably treat it as long as nothing else, symptomatically, like with heat, stockings, walk, and just reassure them that it will resolve.
Okay, BK, indurated more than usual. Ultrasound's normal, no DVT. His saphenous vein is closed.
Fever, white count?
No fever. We didn't check labs at that point. He just came back into the office, so I didn't have any labs. But it hurt. I mean, the guy's, it's not a wimpy guy. He's like limping in the office with this thing.
Yeah, I'd be worried about an overlying infection on top of whatever else may be happening.
So, PO antibiotics, which one would you use? Admit him?
At the very least.
PO antibiotics?
PO antibiotics, and I'd see him again in 24 hours because the last thing we want is for this to spread into a septic thrombophlebitis.
3 days of Levaquin, he comes back in with this. Ed?
Well, yeah, that does look like an infection, so I might even see if there's something I could open up and drain.
All right. BK?
Yeah, you got to open that up. You got to drain it, and you've also got to begin to track whether there's any deep venous thrombosis.
Yeah.
Because you may end up having to excise the vein.
So I got super worried. Ultrasound showed no abscess. I admitted him and put him on full vanc and consulted ID. He was in there for, 10 days. Things got better, but it's the next one, yeah. So, but now, I don't know, 6 months later, he's getting cleared for knee surgery, and the orthopod canceled on the table because he's got lymphedema. And I saw him to clear him, and he's got some lymphedema. So I'm wondering if this is one of these. I don't think he had existing lymphedema, at least not obvious with the classic, foot and toes. But he's got lymphedema now, and I'm wondering if this is one of these where, the saphenous burnt the lymphatic tract and infected, and this, cellulitis can cause lymphedema, so just multifactorial bad luck. But I didn't have to do anything else with the saphenous. That recovered, but he's got a swollen, ankle, foot, and toes. That looks like he's going to keep. So I just saw that as an interesting case. You can make lymphedema worse with saphenous ablation. So be careful of that. There's plenty of cases of that. I did not think this guy had lymphedema going in, but he may have. So this was in '02, a nurse, and I didn't know any better back then, but we all know this now, the saphenous vein was on the dermis, and I did an RF ablation. This is like a year later. She's not happy. So, Ed, when you see this superficial accessory saphenous vein, we call it, or dermal saphenous, or the saphenous that's in this canal here, then exits the fascia and tracks right along the skin, how do you manage those?
Yeah, usually I would fleb it. Is that-
Excise it. And BK, you seen any of these? Pretty common.
I do see them, and I would agree. I would not try to use a laser or IF on it.
So back when we had lasers with long sheaths, I published this, but you burn the top that's in the canal and then sew the vein on using an inversion technique to the actual sheath and make it an inversion stripping. Then now we work with short sheaths, so this is what Ed described. So I just make a couple little incisions and take it out. But do not burn these things. You're going to have a cord and a very unhappy patient. Those things don't go away for a long, long time. So most of you know this already, just a reminder. Vein of the popliteal fossa. Just tell us offhand what you know about these, Ed. How do they behave? How do you treat them? Is there good treatment? Do they recur?
They recur. I mean, I really haven't found anything that consistently works long-term. I've lasered them, I've ligated them, I've foamed them, I've